At the end of July, overlapped into the beginning of August. For those of you who don't know, the first Costello meeting was held in Alabama in 1997. It was a very small...
99.
No, that was Toronto, 99, wasn't it?
Yeah, 12.
Oh, sorry, I got it wrong. 1999. So I've had it wrong all these years.
Okay.
And then we had a relatively large meeting in Toronto 2 years later, and then there's been an international meeting every 2 years since. And in Portland, in 2007, that was a Costello meeting, but it was combined with a research seminar. And that really focused on the recent discovery of the gene and the way Costello syndrome affects people. In 2009, the meeting was held in San Francisco, and it had a much bigger research symposium. And that was the first time we had a combined meeting with the CFC and Noonan groups, and there was also a small NF meeting. And that meeting, because it was in California, was very heavily focused on the pharmaceutical injury, that's a industry. And you may know that HRAS was first discovered, the gene that causes Costello syndrome, was first discovered in 1982 as a gene that's very commonly mutated in human cancers. So there's been huge amounts of work done between 1982 and now on how to manipulate the RAS-MAP kinase pathway, because mutations in genes in that pathway are found in about a third of human cancers overall. So these are somatic mutations, so mutations that occur as a cancer is developing, rather than mutations that we inherit in egg or sperm, which gives you, disorders that we know as Costello and CFC and so on. So mutations in genes in this pathway are incredibly common in human cancers. So there's been a huge amount of work that's gone on, really since the early 1980s, trying to manipulate this pathway, hoping that that would lead to better chemotherapeutic agents. So the meeting in San Francisco had a lot of people from some pharmaceutical companies come and talk about their new chemotherapy agents and whether they might ever be suitable for use in a developmental disorder. In fact, there has been development of very effective chemotherapy for a couple of cancers using the presence or absence of mutations in genes in the pathway as a guide to whether or not you're likely to respond. So that if you have bowel cancer now, and people will look and see if you have a KRAS mutation in your tumour, and that will guide which chemotherapy you actually get. And similarly for malignant melanoma, people look to see if you've got a BRAF mutation in the tumour, and that also guides whether or not you get a particular chemotherapy. So that avenue that people have been pursuing in cancer has actually borne fruit, and I think it will continue to. But people who were clinical geneticists who knew lots of people with Costello or CFC, and people from a paediatric background were really quite nervous about this whole idea. Because, the sort of side effects that you might tolerate, if the choice is either chemotherapy side effects or death, are clearly very different to the sort of side effects that you might tolerate in childhood. And also it's very different if you're thinking about treating someone who's still developing, and particularly someone with a developing brain, but also all other tissues. So a lot of us were really quite anxious about this whole idea that you might use agents that have been developed to treat cancer in developmental disorders. But that was very much the focus of that meeting, and it was a very good meeting. This meeting this year was organised by a paediatric academic cardiologist called Bruce Kerr, who was the person who discovered that mutations in PTPN11 cause Noonan syndrome, along with Marco Tartaglia, who's now gone back to Italy, who's then working in Bruce's lab. And he organised this meeting in Chicago with Amy Roberts, who's a clinical geneticist from Harvard, who's very interested in Noonan syndrome, and they wanted to have this as a much more focused meeting on how we manage patients clinically. And in fact, they called it Back to the Bedside. So it was much less theoretical, if you like, and much more focused on how we manage patients and how these disorders affect families. And once again, it was a combined Costello, CFC and Noonan meeting. Going through the abstracts, then the things that were of interest is that, well, firstly, the Japanese had presented their own prevalence data for Costello and CFC, and they have a well-developed methodology in Japan for looking at the prevalence of rare disorders, which they used, and they came up with a Costello prevalence of 1 in 1.2 million and a CFC prevalence of 1 in 810,000. What we've done in the UK is different in that we've looked at prevalence at birth, and that's ended up with this figure of 1 in 381,000. And I think that is probably slightly an underestimate, because I think there are still some people who are not being diagnosed or who are being called Beckwith or being called child of a diabetic mother or child with severe lethal cardiomyopathy. I think we're probably not recognising still all the children who are very ill and die in very early life. So I think 1 in 381,000 is probably still a little bit of an underestimate. But I do think that CFC is commoner, and it might be twice as common. In Japan it wasn't quite twice as common, but it was commoner. And if that Costello prevalence is about right, and if CFC is twice as common, then it's about 700,000 babies born each year in the UK. So you might expect to see 2 children with Costello syndrome and maybe 4 with CFC. CFC, I think we really haven't got a clue though, because I think it's much harder to diagnose because it is so variable. And I think it'll be a long time before we know just how common it is. But it was of interest that the Japanese, using this fairly consistent methodology, had found that it was a lot more common. The other thing that was of clinical relevance is that, what's the name of the Italian man? There's a paediatrician who works with dysepic babies, his name's just gone out of my head, who's very interested in sleep across the pathway. And his studies have suggested that people with Costello and CFC, one of the reasons their sleep is so difficult is because when we're all born, we don't have a sleep-wake cycle. And we all need to establish a cycle that recognises that there is a difference between night and day. And every baby needs to do that. And he thinks that it's that's the problem in Costello and CFC. He also thinks there are a lot of other reasons why sleep might be disturbed, and they would routinely do a sleep study in all their affected children, which in the first instance would start off being a pulse oximeter to see if you're dropping your oxygen saturation during sleep. So he thinks it's an area that warrants a lot more study, but he did find that if you use melatonin, that did seem to improve this inability to regulate sleep, inability to recognise nighttime as nighttime. And he demonstrated that in both Costello and CFC. So even though melatonin didn't abolish the sleep problem, if you kept a sleep diary, it did increase the amount of nighttime sleep, and he thought that was worthwhile. In terms of the other sort of headline things, then, whereas when we had the meeting in San Francisco and people were talking about chemotherapy, people seem to look at the pathway in the way that Emma drew it out today, which is the easiest way to understand it, as very linear. Increasingly, it's better to sort of try and think of this as a sort of 3 or 4 dimensional model, because it's very apparent that this is a very key pathway in the cells, and so that at all levels of interreaction in that pathway, there might be 3 or 4 or 5 or 6 interreactions with other pathways. So it's easiest to think of it really as a sort of, if the cell's a globe, with this pathway there, but branching out in all directions and affecting multiple processes within the cell. And that does mean that thinking about a treatment that might actually interfere at one point in the pathway is probably not the most creative way to think about it. And people are beginning to think about, well, if we can nibble away at some of these other effects, from these branch actions of the pathway, if you like, would we end up with a situation that was less toxic and less potentially damaging, but might also have beneficial effects. And there's quite a lot of people taking that sort of approach to thinking about potential treatments. The other really interesting area is that people have been using mouse models of NF1 and human studies to try and find out exactly what the problem with learning is in NF1. And it does finally appear that statins make a positive difference to that. And the trials have not yet been published, but it does look like there is going to be a positive difference. And that the basis of that is not just in what you get when you study people before and after statins, but there is a new way of doing cerebral imaging that actually does seem to demonstrate that there is a difference in brain growth and brain connection in the children who are on statins. I thought in a minute Annika might tell you where that is leading us and what the rationale for this neuropsychological research is, but it's really based on that. So if we find that statins truly are beneficial, as I think we are going to find, is the problem that all the children have across the pathway similar, more severe, but similar, and therefore would statins be worth a try? So Annika will tell you a little bit about that in a minute. The other I think, really exciting development is that we know that these are rare disorders, and when we talk about not understanding, like for the heart, for example, really what the risks are, what we call the natural history, we're only going to ever find that out by studying large numbers of people. And I think it's very obvious now that we actually have a very good international collaboration. And so the talk I gave at this meeting was about developing guidelines for management for rare disorders, because we've done that for Noonan syndrome. And so we've set up a guideline group, or two or three, if you like, who over the next year are going to develop a guideline for management for Costello or CFC, using the sort of approach that we've taken with Noonan syndrome. Simultaneously to that, Martin Zenker is a German geneticist who has had a long-standing interest in Noonan syndrome, and he and Marco Tartaglia a few years ago got some funding from the EU, it's called a Euronet project, to develop a mutation database for these disorders. And it actually wasn't terribly much money, but Martin has used that to develop a really excellent and user-friendly clinical spreadsheet so that we can develop a uniform way of recording how these disorders affect people. And so Emma's going to be using that protocol in her research study. And as the second part of his project, Martin is setting up an open access mutation database. And the idea is that any clinician will be able to, when they find a mutation in any of these genes, will be able to anonymously feed that information into the database, and they will then get back clinical information on all the other patients who also have mutations in that gene. So this will be one way of people getting more information, particularly people who have children with a rare mutation in one of the less common genes. This will be one way that people will be able to get more information, and we hope that we will all eventually put all our existing patients into that, both in terms of clinical information and their actual mutation, so that we can end up with good clinical mutation-specific information. The other thing that we hope to be able to do with that is to actually tie that to these guidelines that we develop, with the idea that if we can develop guidelines and then get feedback on how useful those guidelines are, we might be able to end up by doing, if you like, with guidelines that actually have some meaning. So if we've provided a guideline to people, it's a new approach to guideline development. This is called SCAMPS. But what you essentially do is you come up with what experts think is best practice, and then you give that to people. And at the end of the year, they give it back to you and say, well, I didn't do that because for this reason, or I had to do this extra thing for this reason. And then if you collect all that information together, by the end of the year, you've got information about what was useful and what worked and what didn't. So we're sort of hoping that this database that Martin's developing over time might give us a way where the guidelines that we're going to develop over the next 6 or 9 months can be given to people, and then we can get feedback on whether they're right and effective. So I think potentially in terms of how we manage people and how we understand the disorders, this is a really exciting development, because I think that we can probably fairly quickly end up with information from large numbers. And even though it might feel that these are rare disorders and we don't know much about them, we know an awful lot more than we did 10 years ago. And there are things happening. And not only are they happening locally, they're happening on an international scale, and there is very good buy-in from colleagues internationally, which means that anything we find out can be readily shared, but what we can find out is actually so much more powerful and effective because we'll involve more patients. Has anyone got any questions about all of that, or comments?
I was just curious about the statins, how they work. How long a period of time are you monitoring?
The first study they did in Holland was for a relatively short period. Was it 6 weeks or 3 months? It was for 3 months.
Wow.
And it wasn't entirely conclusive, and there were some parameters where it did seem to have a positive effect, but they decided actually that they hadn't done it for long enough, and they hadn't studied the children for long enough after. That's true to say. So the studies that have been done since have been for a longer period of time, but not desperately long, I don't think. I just can't remember. But what was really amazing was the changes in these brain scans.
And was that, were those changes permanent as long as they were taking statins, or did it?
I don't think we would know that as yet.
Okay.
But certainly I think one of the really big difficulties in childhood anyway is that if you took something that improved your concentration and behaviour and decreased your distractibility in class, then there are likely to be spin-off effects that are related to the different way that people then treat you. Do you know what I mean?
Yeah,
so
exactly.
I think it's really hard to tease out, actually. But the doses of statins are not particularly large from memory. So it is quite an exciting concept. But I think trying to demonstrate that across the pathway, the severity of the deficits might be different, but if the pattern is similar, then that would mean it was much easier to justify trying other things. Any other?
Similar sort of question, but about the melatonin sleep issue you were mentioning, and that doctor had found that melatonin helped in sorting out that cycle between night and day. Did it only help whilst it was being taken, or could you use melatonin in order to learn to train the brain and then stop using it and the brain would stay trained?
I think you probably didn't know that, but I think it would be like all sleep disorders. If you can use whatever you can to re-establish a new pattern, it can be an important part of that. Melatonin is generally well tolerated, so taking it in the longer term is not really a big problem. One of my colleagues, who's a community paediatrician in Blackpool, has just been doing a PhD actually on the impact of sleep disturbance in families where there is a child with developmental disability, and the impact on parents' time and sleep and the whole family dynamic. But she was part of a national study that looked at melatonin in a general population of children with developmental disability, and actually demonstrated that the increase in sleep was very small from melatonin. But it did seem from these Italian studies that in these particular disorders where you don't have this proper sleep cycle, that it might be a bit more beneficial than that. But I think what Megan would say is that you have to do a sleep diary, because she says that what people, that's what she learned from doing her PhD. What people remember of sleep and lack of sleep is distorted by lack of sleep.
Yeah.
So you have to do a sleep diary, and you have to do it for a couple of weeks before you try anything, and then you have to keep doing it. And so that because what you think is happening will be different to what is actually happening. She sent me an example of a sleep diary, actually, if anyone wanted one, we can put it on the website.
Same as sleep apnea. So
No.
What is,
Sleep apnea is when you stop, you have a temporary cessation in your breathing while you're asleep, usually because you've obstructed your airway, because your tongue's falling back, or in an adult because you're snoring, or your tongue is obstructing the back because of your obesity or whatever.
Because that's been quite a big thing on the American list, though.
It has.
Talking about the apnea.
It has. And that's one reason why, is it called Delamarco? Yeah, Delamarco, who's the paediatrician who works in Rome with Giuseppe Zampino, thinks that everyone should be having a sleep study. And I think he's right, actually.
Because Nancy suffered from that many years ago, they didn't know that's what it was then.
And in terms of the Chiari too, if you get sleep disturbance and apnea, it can be a symptom of the Chiari. So I think that there's good reasons for doing it now.
Because apnea can also be quite dangerous if they're going to be going under anaesthetic. Is that right? I don't know. Anaesthetic?
Well, I think if you had, large tonsils and adenoids, which might be contributing to apnea, then that might be a problem for anaesthesia. Okay, so without further ado, I'll introduce Dr. Kay Hood, who's once again a person who works in the Royal Manchester Children's Hospital. She's very kindly